So today we are discussing about a topic called hypertension. This is the topic, hypertension. When you're dealing with hypertension, we must understand one thing. Okay. So what is the definition of a hypertension? It is defined as the presence of blood pressure elevation to a level that places patient at increased risk of target organ damage in several vascular beds, including the retina, brain, heart, kidney, and large arteries. So that is the target organ involvement. Target organ involvement. Hypertension which causes target organ involvement. That is the problem here. So the pressure increases, blood pressure increases to cause increased risk for the target organs. So we will discuss what are the target organs are involved. First one is large vessels. When dealing about large vessels, there is aneurysmal dilatation. Aneurysmal dilatation. What is the first problem? Second problem is accelerated atherosclerosis. Third problem is aortic dissection. So when considering a large vessel, these are the problems that are encountered when the blood pressure is increased. Okay, that is dilatation of the vessel, accelerated atherosclerosis, aortic dissection. Then coming to the second problem, which is the second end organ damage that causes is the cardiac, that is the heart. What all problems that heart can occur in acute cases, in acute increase in the pressure or the BP, it can cause pulmonary edema. Next, it can cause MI, that is myocardial infarction. In chronic cases, the chronic cases, it can cause CAD, that is coronary artery disease, LVH. Okay, so that is about the cardiac causes. Third one is the cerebrovascular, that is the CNS, cerebrovascular. So similarly, acute occurrence of target organ damage in CNS is IC bleed. You see, when a hypertension, high blood pressure, it bleeds into the brain, intracranial hemorrhage. It can go for coma, for seizures. Likewise, it can go. In chronic cases, it can cause transient ischemic attack or stroke. Transient ischemic attack or stroke it can cause. Next comes the fourth one, that is the renal. What are the target organ renal damages that can occur? Similarly, acute cases, the renal, it can cause hematuria. Also, it can cause azotemia. What is azotemia? Azotemia is just means that the high blood urea nitrogen. These are azotemias. Okay, high blood urea nitrogen. Next comes the fifth problem, that is coming to the eye. Eye, it can cause a retinopathy. Retinopathy, that is because of acute, it can cause papilledema, or it can cause hemorrhage. It can cause hemorrhage as well as exudates, as well as arterial nicking. These are the major problems while dealing with the eye. So next comes the classification of the blood pressure. Classification. How you classify the blood pressure? That is the hypertension. First class is the normal BP. If a clinician is telling you that you are having a normal BP, what does it mean? It means that systolic blood pressure is less than 120 millimeter of Hg, and your and the diastolic blood pressure is less than 80 millimeter of Hg. Both those thing has to be there. If either of the one is deranged, it is cannot be told as a normal BP. Next, What is pre-hypertension? Pre-hypertension. What is that? Pre-hypertension. When you're dealing about pre-hypertension, the systolic blood pressure, is between 120 to 139 millimeter of Hg. That is systolic hypertension. When coming to the or it can be diastolic BP. Either it is enough. Either one of it is enough. Is 80 to 90, 80 to 89, 80 to 89 millimeter of Hg. So either of the one is enough. If your systolic BP is between 120 to 390, 120 to 139, and the diastolic BP is normal, then also you can call him as a pre-hypertensive patient. Or the systolic BP is normal, or the diastolic BP is 88 or 86, or between 80 to 89. You say that the patient is a pre-hypertensive patient. These patients should engage in compensative lifestyle modification to delay progression or to prevent the development of hypertension. Pharmacological therapy should be initiated in pre-hypertensive patient with evidence of target organ damage or diabetic. So in this patient, no pharmacological drugs are required as of now. If patient is having a target organ damage or a diabetes mellitus, target organ damage we have already told you in the previous slide. These are the target organ involvement: cardiac MI, cerebrovascular stroke, renal hematuria, or you see the creatinine level is high. In retinopathy, you see the papilledema or like that. If any of the targets organ involvement and there is a diabetes mellitus, either of one, you have to start with the drugs. Otherwise, lifestyle modification is enough. Okay. So next, another topic is called stage 1 hypertension. In stage 1 hypertension, the systolic blood pressure is 140 to 159 millimeter of Hg. That is, systolic blood pressure is 140 to 159 millimeter of Hg. That is stage 1. Diastolic blood pressure 90 to 99 millimeter of Hg. So either of this. If you see a BP of 140 to 159 in systolic, or you see a diastolic blood pressure of 90 to 99, you can very well group that patient into a stage 1 hypertensive patient. When coming to stage 2 hypertensive patient, stage 2, the systolic blood pressure is more than 160 millimeter of Hg. The diastolic blood pressure is more than 100 millimeter of Hg. So these are two stages: pre-hypertension, stage 1, stage 2. So the pharmacological therapy should be initiated in addition to lifestyle modification to lower the blood pressure to less than 140/90. In patient without diabetes or chronic kidney disease and whose age is less than 60. For those whose age is more than 60 without diabetes or chronic kidney disease, the pharmacological therapy should be initiated in addition to lifestyle modification to lower BP less than 150/90. So in patient with diabetes or kidney disease age more than 18, the BP should be lowered to 140/90. So our target is less than 140/90 millimeter of Hg. This is our target. Okay. In patient with a diabetes or CKD, in a patient with a diabetes mellitus or CKD and age is more than 18, our target should be is less than 140/90. Patient with a blood pressure more than 20/10 above their treatment target will often require more than one medication to achieve adequate control, to drug regimen. That is, if 140/90 is our target, the patient is having a 160 or 160/90 or is having 140/100. In such case, you at least require two drug regime. You require two drug regime to control. That is, the increase is more than 20/10 millimeter of Hg above the normal control level. That is 20/Hg above the normal control level. It is high, so we use two drug regime to control the BP. Patient with an average BP of 200/120 or greater require immediate therapy, and if symptomatic end organ damage is present, you should hospitalize the patient. Okay. Next, you see that what is called a hypertensive crisis. In a hypertensive crisis, you see that hypertensive emergencies and urgencies, it usually develops in patients with a previous history of elevated blood pressure, but may arise in those who were previously normotensive. The severity of hypertensive crisis correlate not only with the absolute level of BP elevation, but also with the rapidity of development, because autoregulatory mechanism have not have sufficient time to adapt. So two subunits are hypertensive urgencies. The second one is hypertensive emergency. So these two are the subtypes. The crisis condition. When dealing about hypertensive urgency, if you're having an urgency, hypertensive urgency, which means substantial increase in BP, usually with a diastolic BP more than 120. Okay, a substantial increase in BP with a diastolic BP more than 120 occur in approximately 1% of the patients who is having hypertension. Hypertensive urgencies, that is upper level of stage 2 hypertension, hypertension with optic disc edema, progressive end organ complications rather than damage, and severe perioperative hypertension. So these warrants BP reduction within several hours. So end organ damage will occur. That is, you see optic disc, there are optic disc edema. You see end organ complications that we discussed already. In such cases, you should immediately reduce the BP. That is urgency. In hypertensive emergency, in hypertensive emergencies, you see it's also called accelerated hypertension, typically defined as a systolic blood pressure more than 210 millimeter of mercury, diastolic blood pressure more than 130 millimeter of mercury. This is a hypertensive emergency or accelerated hypertension. It requires the presence of papilledema. In malignant hypertension, there is papilledema. Okay, in malignant hypertension, there is papilledema. So, isolated systolic you see one thing. The patient present with headache, blurred vision, or focal neurological symptoms. And if it is papilledema, also there is malignant hypertension. Otherwise, it is accelerated hypertension. It requires immediate BP reduction by 20 to 25% reduction should be there urgently. Otherwise, it's very lethal to prevent or minimize end organ damage. That is a hypertensive encephalopathy, intracranial hemorrhage, unstable angina pectoris, MI, LVF with pulmonary edema, dissecting aortic aneurysm, progressive renal failure, or eclampsia. Next come another is isolated systolic hypertension. That is systolic blood pressure more than 140 millimeter of Hg. Systolic blood pressure more than 140 millimeter of Hg. And he will be having a normal diastolic blood pressure. It occurs frequently in elderly, beginning after the 5th decade and increase with age. So non-pharmacological therapy should be initiated with medications added as needed to lower systolic blood pressure to appropriate level based on age. So you see here, hypertensive crisis. Urgency means diastolic blood pressure more than 120. Emergency means systolic blood pressure more than 220 or diastolic more than 130. So both are to satisfy. Okay. So next comes the epidemiology. You say that it's not at all important. When you classify the stage hypertension, you see that one more we'll see normal case, the systolic blood pressure and the diastolic blood pressure. In normal case, it is a 120, less than 120, and less than 80. If it is a pre-hypertension, then it could be 120 to 139 or the diastolic blood pressure is 80 to 89. There is or. Stage 1. Stage 1 hypertension, that is 1 to more than 140, that is 140 to 159, or you see that a 90 to 99, that is a diastolic. Stage 2. Stage 2 hypertension is a more than 160 or more than 100. This is it. Okay. So then comes the etiology. Why this occur? You see, etiology, the BP increases with age. Other contributing factor includes overweight, obesity, increased dietary sodium, decreased physical activity, increased alcohol consumption, and lower dietary intake of fruits, vegetables, and potassium. So less potassium is very important. Vegetables is very important, and physical activity is very important. So these all things are contributing to the formation of a BP. Overall, hypertensive patient, more than 90% have primary or essential hypertension. The remainder have secondary hypertension due to many causes. Primary hypertension means it is called essential hypertension, which is probably idiopathic, or it can be due to age related. Secondary hypertension, secondary to another cause, like it can be renovascular disease, it can be pheochromocytoma, pheochromocytoma, or it can be Cushing syndrome. It can be primary hyperaldosteronism. It can be dilatation of aorta. It can be sleep apnea. Obstructive sleep apnea. Or it can be autosomal dominant condition or autosomal recessive condition sometimes of adrenal renal axis. Adrenal renal axis. That result in salt retention. Okay, so quickly go through the causes of secondary. It can be renovascular disease, pheochromocytoma, Cushing syndrome, primary hyperaldosteronism, coarctation of aorta, obstructive sleep apnea, autosomal dominant recessive cause of adrenal renal axis that result in salt retention. These are secondary causes. So next comes the diagnosis. You see that the BP elevation is usually discovered in asymptomatic individuals during routine health visit. Okay, optimal detection and evaluation of hypertension that require accurate non-invasive BP monitoring, which should be obtained in a seated patient with the arm resting level with the heart, with the level of the heart. So you see a calibrated, appropriately fitting BP cuff should be used, because falsely high reading can be obtained if the cuff is too small. Two readings should be taken, separated by 2 minutes. Systolic blood pressure should be noted with appearance of Korokov sound, phase 1, and diastolic blood pressure with the disappearance of sound, phase 5. So some important points, that is a 2 reading, 2 minutes apart. That is a phase 1 Korokov sound is for a systolic blood pressure, and phase 4 to phase 5 is for a diastolic blood pressure. In certain patients, the Korokov sound do not disappear but are present at 0 millimeter of Hg. You see, in some patients, I also encountered such situations. The Korokov sound, it won't disappear. At 0 millimeter of Hg itself, the Korokov sound is present. In this case, the initial muffling of Korokov sound, that is phase 4, is taken as diastolic blood pressure, phase 4. We won't wait till the phase 5, we initial muffling of Korokov sound, phase 4. Okay. So one should be careful to avoid reporting spuriously low BP reading due to an auscultatory gap, which is caused by disappearance and reappearance of Korokov sound in hypertensive patients, and may account for up to 25 millimeter of Hg gap between the true and the measured systolic blood pressure. Next, you see, you should be confirming with the both arms. Okay, history. You ask the history to the patient, that supplements that can affect BP. So whether the patient is taking any medications or any supplements that increases BP, what are they? That is decongestants. These are decongestants, oral contraceptive pills, appetite suppressor. You see some symptomimetic drug. And TCA, that is cyclic antidepressant. Then MAO inhibitor. Then chlorpromazine, which is an antipsychotic. Then steroids. Use some NSAIDs because it blocks prostaglandin, that is a dilator, vasodilator. Caffeine, thyroid hormone. Then alcohol, etc. Okay. So mainly you think about this one: NSAIDs, steroids, TCA. You see decongestants and OCPs. There are some secondary causes, that is presence of medications and supplements that affect the BP. A diagnosis of secondary hypertension should be considered in the following situation. Secondary hypertension means that due to some other causes, as we all discussed, renovascular causes, pheochromo, Cushing syndrome, some aldosteronism, OSA, obstructive sleep apnea, coarctation. So when you suspect such a secondary hypertension, you are suspecting a secondary hypertension. What all things you should keep in your mind? First, a diagnosis at the age at onset, younger than 30 or older than 60. If it is older than 60, you should suspect secondary hypertension, or if it is younger than 30, you should suspect secondary hypertension. Next, hypertension that is difficult to control after therapy has been initiated. You treat it with a drug, but it is difficult to control. Next, stable hypertension that become difficult to control. Clinical occurrence of a hypertensive crisis. The presence of signs or symptoms of a secondary cause, such as hypokalemia or metabolic alkalosis. That is not explained by diuretic therapy, not explained by diuretics. Hypokalemia, potassium lowering. Potassium has got some wider effects. That is potassium vasodilatory effect. If potassium is low, the dilatory effect is gone. In metabolic alkalosis, you see in metabolic alkalosis, sodium and water retention and potassium excretion. These are retained potassium excretion. So it's associated with increased. So it means that there is a signs of volume expansion because sodium and water retention. Excess mineralocorticoids as the explanation for the metabolic alkaloids. Aldosterone and glucocorticoid other than dexamethasone stimulate renal loss of acid and potassium and thereby generate and maintain alkalosis. So this is the main reason for the alkalosis. Next comes the patient who present with significant hypertension at young hypertension. A careful family history may give clue to form a hypertension that follows simple Mendelian inheritance. So you see, secondary hypertension, you think about a patient more than 60, less than 30. Already given drug, but it is not controlling. Hypokalemia, metabolic alkalosis. This should be suspected. When you're suspecting these things, for example, primary hyperaldosteronism, metabolic alkalosis, primary hyperaldosteronism, aldosterone increases. Aldosterone. That's why. So in these cases, you should suspect a secondary hypertension. You should order the investigation to find out the cause. Next comes the differential. No, if you examine physically the patient, what all thing you can hear? Physical examination. When you examine the patient physically, you could see that you should do a first investigation for target organ damage or a secondary cause of hypertension by noting the presence of carotid bruit. Then S3, S4. Cardiac murmurs. neurological deficits, elevated JVP, rails, retinopathy, unequal pulse, retinopathy, unequal pulse, can be coarctation, unequal pulse. Probably it can be coarctation in unequal pulse. Enlarged or small kidney, cushingoid features, abdominal brood, small kidney or enlarged kidney. Small kidney or enlarged kidney means perfusion will affect, resulting in RAS activation, causing a increased blood pressure. Next is abdominal bruit or and cushingoid features. When you're seeing a cushingoid feature, what are the cushingoid feature you see? This is a cushingoid feature. This is also a patient showing a cushingoid feature. So, cushingoid feature like this: fat parts, buffalo hump, red cheek, abdominal tracts marks, bruise, pendulous abdomen, thin arms and legs. These are the features of a cushingoid body. So when you're seeing suspecting that, you should suspect of a Cushing syndrome. Also, when you're seeing abdominal bruise, can be or the aorta of abdominal renal arteries, stenosis or something problem. So you can use a USD to completely diagnose it. So what are the differential diagnosis when you are seeing this? A differential diagnosis. You see, hypertension may be part of several important syndrome of withdrawal from drugs, including alcohol, cocaine, opioid. Rebound increase in BP also may be seen in patients who abruptly discontinue our antihypertensive therapy, particularly beta blockers and central alpha 2 agonists like clonidine, apraclonidine, like monidine. The cocaine and other sympathomimetic drug, amphetamine, phencyclidine, hydrochloride, can produce hypertension in the setting of acute intoxication and when agents are discontinued abruptly after chronic use. See, cocaine and some sympathomimetic drugs like amphetamine, can be phencyclidine derivative, hydrochloride. So can produce hypertension in the setting of acute intoxication and withdrawal. You see, hypertension is often complicated by end organ insult. It's an ischemic heart disease, stroke, seizure. If there is an acute episode of hypertension, that is acute setting. In an acute setting, you can treat with the patient like phentolamine and nitroprusside or nitroglycerin or nitroprusside. The phentolamine is actually a alpha adrenergic receptor blocking property. Okay, so the test needed to help the identify with the possible target organ damage to help assess cardiovascular risk and other adverse effect of the therapy. So you should do some basic test before starting the treatment. That is urine analysis. You can see any kidney problem. Then PCV, hematocrit. You can see glucose, that is a diabetes or not. You can check the serum potassium, because always sold in mineralocorticoid excess, it can be sodium water retention and potassium excretion, it causing metabolic alkalosis, hyperaldosteronism. And serum creatine, kidney problem. Serum calcium, serum uric acid. Because in serum uric acid, the excretion is very important, kidney functioning. Then lipid profile, fasting lipid profile. So calcium is very important because reduced intake of calcium is frequently associated with high levels of parathyroid hormone. So this is associated with moderately reduced bone mineral contents, bone mineral density. High level of serum parathyroid are associated with high blood pressure, because reducing calcium means it affects the blood pressure. So increase the calcium should be a normal level, otherwise the blood pressure can increase. Okay, thank you.